Preventing or surviving common breastfeeding problems. Making breastfeeding work for you. Common sense and compromises. The enemy of good is perfect. Women often work so hard to do breastfeeding perfectly, they follow all the rules and recommendations so exactly that they run themselves ragged. Breastfeeding advice can be given so plentifully and contradictorily that it becomes impossible. I highly recommend that you approach breastfeeding with common sense and flexibility. There are a few scenarios I see over and over again that can be tricky to navigate. It's important to have a plan to sidestep these pitfalls. I've already discussed delayed letdown, so let's get to the rest. Toughening nipples before birth. Nipples are connected to deeper breast tissue by ligaments, fascia, and ducts. These hold the nipple tightly in place. When your baby first begins to nurse, these connective tissues are pulled on and stretched. It can feel quite tight during the first days you nurse. You can help stretch them out before birth by simply rubbing your towel over your nipples a few times after every shower during your last trimester of pregnancy. This can increase the mobility of your nipples and make that first week of feeds a bit easier and less tender. The positioning of the baby in nursing is important. Before you leave the hospital or birthing center, please make sure you ask the newborn nurse or lactation consultant to assess your baby's latch. Getting your baby to feed in the proper position is essential for easy feedings and preventing cracked nipples and other problems later on. Your areola should be almost entirely within the baby's mouth. If your baby takes in only the nipple and not enough of the surrounding areola, it puts all the suction pressure on a small surface area. This greater pressure, repeated over several feeds, can result in blisters on your nipples. Blisters are much better prevented than endured. If your baby needs to gain weight faster, a pediatrician may tell you to feed your baby every 2 hours. They often are not thinking of what this means to the mother at night. Feeding your baby every 2 hours means you will never get more than 1 hour of sleep in a row unless you are able to enlist help. It's not good for your mental health to become that seriously sleep deprived. If your doctor tells you to feed your baby every 2 hours, clarify if this means through the night as well. Most of the time, doctors are okay with every 2 hours during the day and every 4 hours at night. Either way, you need to create a plan for support. Can a bottle be given by your partner for a couple of the nighttime feeds? Can family or friends come each day so you can take a nap? Create a plan to make sure your needs can be better met. Q2 feeds, meaning feeding every 2 hours, without a self-care plan in place can trigger postpartum depression. Tongue-tied ankylosing. Tongue tie is a common cause of painful or poor latch. Tongue tie is caused by a tight lingual frenulum, the ligament under the tongue. When the lingual frenulum is short, it prevents the tongue from being able to extend up. This prevents a proper latch, making breastfeeding kind of slow and sometimes pretty painful. The discomfort of the latch with the baby with tongue tie begins within the first week of nursing. A simple procedure can fix this problem. It's performed by ear, nose, throat doctors, some dentists, and some pediatricians. To find one that is experienced in the procedure, ask your pediatrician or lactation consultant. When tongue tie is repaired, moms will immediately notice a significant difference in feeding. It no longer hurts, and the baby is much less frustrated with feedings. Failure to treat ankylosing can result in quitting breastfeeding prematurely. It can also later sometimes impair your child's speech and have difficulty whistling or licking an ice cream cone. Milk ejection reflex. I once read a male obstetrician state that breastfeeding never hurts if done properly. Yes, breastfeeding is a wonderful experience. However, sometimes breastfeeding can be uncomfortable or even hurt. I've mentioned a few causes, and another can be the milk ejection reflex. Most women do not experience this pain. And for those that do, it's short-lived and usually fades away within the first couple months of breastfeeding. Sometimes you see it described as tingling or a twinge. I had it, and for me, I would say it was more like a burning needle jabbed into my boob. I would call it more excruciating than tingling. It is a contraction of the milk ducts to propel the milk towards the nipple, initiated by the release of oxytocin. It's a fleeting pain, but it can be intense. So hang in there. When it goes away, you will be left with all the wonderful parts of breastfeeding a baby without any of the pain. It's usually gone within a couple months. Sometimes all is going well, and then out of nowhere, problems can start. If you have pain with breastfeeding, tell your doctor or midwife. They can evaluate you to make sure you don't have yeast on your nipples or thrush in the baby's mouth. Speaking of which, clogged milk ducts and mastitis. Milk ducts can get clogged, which can sometimes lead to mastitis, an infection within the breast. If you have this, you will notice that part of your breast is red, painful, and swollen or hard. You may even develop fever and chills. It's safe to continue breastfeeding. In fact, it actually helps clear the infection. Hydrate to keep your milk supply up. If you have mastitis, massage the area towards the nipple while you nurse or pump to help clear the blockage. Breastfeed on the affected side first with each feed until your mastitis clears. Vary nursing positions. Cabbage leaves on the breast can help with the discomfort. If home treatments don't help within a couple days, you develop a fever, or you're feeling worse, contact your doctor. Antibiotics may be necessary. Thrush. This is the overgrowth of yeast in the baby's mouth or on your nipples. It is often caused by moisture collecting around your nipples for prolonged periods of time. To prevent this, if you notice that your nipples leak, wear absorbent pads and switch them out whenever they become moist. There are other causes for thrush as well. If you and your baby take antibiotics for an infection, such as an ear infection or a mastitis, the antibiotics can kill the bacteria, allowing normal yeast to overgrow. A sign that you might have yeast is that successful breastfeeding turns suddenly painful, especially after your baby has taken antibiotics. Sometimes you can see a white coating on the baby's tongue, or a diffuse tender redness can be noticed on your nipples. A family doctor or pediatrician can easily treat thrush with a prescription. The medicine should go on your nipple and in each cheek of your baby's mouth, increasing your milk supply. Low milk supply is a common fear. When you breastfeed, it can be difficult to tell if you're making enough milk. There are 3 clear indicators. 1, your baby appears satisfied and disconnects from the breast on their own. 2, your baby has frequent wet diapers. Or 3, your baby's gaining weight appropriately at their well-child visits. To help ensure good milk supply, hydrate well. Drink 8 ounces of water each time you nurse, plus several extra glasses a day for you. If you exercise or live in a hot climate, you may need more. Nurse for 15 to 20 minutes on each side. Give yourself time and space to let your milk come down. If you need additional milk or to increase your breast milk supply, you may need to pump. Try to time pumping either directly or after nursing within an hour. If you pump just after nursing, you might not get much milk, but repeatedly doing this trains your breast to make more. Avoid pumping in the hour before you expect your baby to want to nurse. A baby can get really frustrated when they're hungry, but the breasts have recently been pumped dry. Do not interrupt your sleep in order to pump milk. Your sleep is paramount. Note that some allergy medications can decrease milk supply. If you're taking any medications, ask your doctor if they could be affecting your milk production. Talk to a lactation specialist for extra ideas. If none of it works, don't judge yourself. We can fight biology, but we don't always win. Giving your baby a mixture of breast milk and formula called partial breastfeeding can make sure your baby gets the antibodies and also the nutrition they need to grow and thrive. Baby refuses bottles. A baby refusing to take a bottle can make returning to work or getting childcare support very difficult. It also means that every nighttime feeding must be done by you, so you don't get any breaks. To prevent bottle refusal, I recommend you give your baby bottles of pumped milk starting when your baby is about 3 weeks old. This may differ from common recommendations you may have been given, and I'll tell you why. If you wait until your baby is a month old, they're more awake and aware. They notice the difference between breast and bottle right away, and some of them are not happy about it. It can be terrifying to know you are returning to work, yet your baby absolutely refuses to take a bottle. How will they eat when you're at work? When you introduce a bottle earlier, around 3 weeks of age, babies are much more accepting of it. Continue to give your baby a bottle at least several times a week. When your baby takes bottles, you'll have more support at night, and dad gets to enjoy feeding his infant as well. If you need help to learn how to use your pump, ask a lactation specialist. Dysphoric milk ejection reflex, DMER. This less recognized phenomenon describes an abrupt onset of intense feelings during milk letdown. Women with DMER describe feeling sad, worried, tearful, angry, or emotionally empty. These feelings can range from mild to quite severe. Unlike PPD, in which symptoms last a significant part of the day, DMER is brief, lasting just a few minutes during letdown. One study showed that 9% of women reported experienced DMER, but this is only one study. We're waiting to get more information on this. I suspect the number's much lower than that. The cause of this phenomenon is not yet understood, although it is likely a reaction where oxytocin initiates an atypical neurotransmitter response. This reaction is the opposite of the more common feelings of love, calmness, and trust that usually occur in response to oxytocin at letdown. It is unpleasant, sometimes extremely so, but it is not a disease. Notice the feeling, yet attach no meaning or significance to it. Label it and let it go. This is a biological response like an emotional misfire. Focus on your breathing. Slow and deepen your breath. Allow the feelings to wash over you and then subside. It's a bit like getting on a bad roller coaster. The ride may not be pleasant, but it will end. You can use this experience to practice tolerating unpleasant feelings, which is not only useful for DMER, but for life. To cope with DMER, we want to balance this negative experience with extra self-care. Make yourself a warm cup of tea, sit in a cozy spot, put on relaxing meditation, podcast, or music while you nurse. Try to make it like a spa experience. Have positive touch with your baby at times when you're not nursing, so you don't associate the closeness to your baby with this unpleasant feelings of DMER. Practice infant massage and have positive skin-to-skin contact at other times with your baby. DMER can fade away on its own after a month or two, although in some women it doesn't go away until they stop breastfeeding. Sometimes pumping causes less of a reaction, so some moms switch to pumping breast milk instead of breastfeeding. Therapy can also be helpful in the process of figuring out what works best for you. Some women choose to stop nursing because of DMER. Others continue despite it. Only you can choose what is right for you. Pumping breast milk at work. Before you begin nursing, it can be hard to know what you will need. Ask your friends who have pumped at work for recommendations. Find out which products and routines worked well for them. Do not waste your time with a poor quality breast pump. They are slower and less effective. If you have an on-the-go job or one that lacks a private place to pump, the hands-free style tubeless pumps, such as Willow or Elvie, can dramatically reduce your stress. You wear them in your bra, and the milk is pumped into the self-contained system. It can be difficult to pump in the workplace. Laws vary by state, and attitudes vary by employer and supervisor. Even as a physician in healthcare, my employer refused to provide time for pumping. It was something I was certainly allowed to do, but I was still expected to see the same number of patients as everyone else during the same amount of time. Needless to say, their expectations were not realistic. With this kind of stress, it can be very difficult to relax enough to allow the let-down milk reflex to occur. This attitude of permitting pumping but taking no steps to facilitate or support it is common in the workplace. As part of the Affordable Care Act, a federal law passed in 2010, under which employers are required to provide reasonable unpaid break time for nursing mothers to pump milk. Employers are required to provide a private space other than a bathroom until the baby turns 1 year old. There's a caveat exempting businesses that employ less than 50 people if creating this space would impose an undue hardship or expense or difficulty. For more information, see the United States Breastfeeding Committee's website, www.usbreastfeeding.org. Most states have laws requiring employers to provide break time and space for pumping. Check out the Center for Work-Life Laws at Pregnant at Work website to learn more. Pregnantatwork.org also provides clear information on what setting you will need in order to breastfeed at work so you know what to ask for. And it provides doctors with clear directions of what to request in asking for a workplace accommodation. Discuss with coworkers what their experiences were. If the conditions for pumping are lacking or of poor quality, talk with HR about your concerns. If there are systemic work issues, join with other women for support and greater influence. You will have more energy to address these issues before the baby comes than after. Weaning. The final booby trap I want to mention is weaning your baby. When you or your baby decide you're ready to wean, do it gradually. Drop one feeding at a time. Sudden cessation of breastfeeding can cause a hormonal fluctuation leading to a period of dysphoria and possibly depression. Although I spent a lot of time talking about what can go wrong in breastfeeding, I don't want to give you the sense that it's a terrible stressor to endure. I mention these problems so you can avoid them and spend more of your time enjoying it. The times you spend nursing your baby can be some of the most special memories you will keep.